Hi, folks, and welcome back. This week, we're going to spend some time reflecting on the conditions we have found ourselves in over the past month. We are going to reflect on some philosophical and ethical questions that arise as a result of the COVID-19 pandemic and our individual and social responses, political, cultural, and economic responses to the pandemic. We find ourselves today in a position that none of us have been in our lifetimes. We've not been here before. Looking today at the numbers from Johns Hopkins University, we see that there are here on April 7th, 1,428,428 confirmed cases of COVID-19 globally, with just over 82,000 deaths recorded. In the U.S. alone, today there were 398,185 cumulative cases, and today we crossed a threshold of 10,000 deaths. We have 12,844 deaths currently attributed to COVID-19, and that is rising rapidly, and it's highly likely that that is in fact an undercount of the number of deaths caused by this pandemic, and certainly an undercount of the number of deaths caused by the pandemic and our response to it, because that response is itself costly. We find ourselves in a place where we are currently quarantined. We have been told to shelter in place. Most of us have been told to shelter in place, to go out only for necessities, to limit our interaction with people outside of our homes, and when we do interact with them, to maintain a physical distance of at least 6 feet between ourselves and others, to wash our hands vigorously and religiously, to wear face masks now when we leave our homes or when we're going to be in places where we are interacting with other human beings. We are living in highly isolated conditions that exacerbate the isolation of folks who are already socially isolated, and that create significant psychological, emotional, and economic strain for many of us, not to mention the fact that we are having to navigate living in households with our families who we normally interact with in our normal everyday capacities, but don't spend 24 hours a day with. So there's much in our life that has changed and that calls for philosophical reflection. There are a variety of questions we might ask about the COVID-19 pandemic and our responses to it. We might wonder what we can learn about ourselves. We might wonder what we can learn about the human condition, about the precarity of the human condition, about the necessity of social interaction in our lives, about the interconnectedness of human beings. We might wonder what we can learn about society, about the demands of the social contract and how best to enact it. We might wonder how we can build a better society in the aftermath of COVID-19. We might wonder how we can make ourselves more resilient, how we can make our institutions more resilient, how we can prepare ourselves for future pandemics and for the social and economic strains that are going to be caused by crises exacerbated by climate change. We might ask what obligations we have to engage in social distancing or physical distancing, to wear masks, to wash our hands, to practice social solidarity, to care for one another. What sorts of obligations do we have toward one another in these circumstances? What should motivate us to engage in social distancing, to maintain this quarantine that's likely to last for months? What should be what ethical reasons are there for us continuing this difficult and stressful practice. We might also want to explore how long-standing structural problems are exacerbated by the pandemic. We know that problems of racism, of sexism, of class divides, of economic inequality are being exacerbated by this pandemic. We've seen that, for example, certain groups face disproportionate burdens as a result of the pandemic and as a result of our social responses to us. And we might wonder what that reveals about us. We might wonder what it reveals about us that African American communities seem to be heavily impacted by COVID-19, both in terms of the spread of the pandemic and in terms of the mortality rate of the pandemic in those communities. We might wonder how this reflects social the social structure that is in place in our society, how this reflects the fact that members of these communities are largely impoverished and might still need to go out and work or still need to go out and interact with others, putting themselves at risk in order to make ends meet, in order to be able to put food on their table. We might also wonder how, or reflect upon how the increased mortality rate likely results from a disproportionate number of pre-existing conditions among minority communities as a result of the stresses they live under in a white supremacist, racist society. What does this reveal about us? What does it reveal about us that that some of the poorest among us, some of the lowest among us are bearing disproportionate burdens in this pandemic, that those who we did not practice social solidarity towards prior to the pandemic, those like grocery store clerks and garbage collectors and nursing assistants, are being called on now to practice social solidarity toward us. They're being called on to bear significant burdens, to bear the lion's share of the risk associated with the response to this pandemic. They're being called on to continue working when the rest of us are staying cloistered in our homes. We also might want to think about the trade-offs between harms that result from COVID-19 and harms that result from social distancing and its social, psychological, and economic impacts. There's likely to be a spike in psychological ailments, a spike in psychological conditions as a response to this social isolation. There's likely to be a spike in suicides, in rates of addiction as a result of the impacts of social isolation. There's likely to be an increase in the mortality rate among those who are already in socially precarious and isolated situations. And the economic impacts have been significant. We've seen over the last 2 weeks the largest 2 weeks of unemployment numbers ever. Employment claims are skyrocketing. Businesses are closing. We're likely to face economic strain for months and years to come as a result of this pandemic. So how should we think about those trade-offs? And how should we think about the trade-offs between the common welfare and individual liberties? We're being asked to restrain our individual activities for the common good. Those of us who are young and relatively healthy might think that we are bearing a significant burden in not being able to interact with others and not being able to go out and put ourselves in the marketplace. And we might wonder why our liberties can be curtailed in this way for the common good if we don't recognize it as a significant risk to ourselves. So all of these are questions that I hope we'll have time to explore in class. I hope we'll be able to dig into them and really have some good conversations about them. I want, for the remainder of my time in this short lecture, though, to focus on the question of the allocation of scarce resources, because a central question that we're going to face during this pandemic is how scarce medical resources ought to be used. We have seen in Italy, in northern Italy, especially in the Lombardy region, a need to ration medical care, a need to ration access to ventilators for patients suffering from COVID-19, and we are beginning to see similar needs arise in New York as the pandemic peaks there. And we're going to see similar needs arise in cities around the country as the pandemic peaks in those cities. In the DC-Baltimore region, for example, we're now designated as a future hotspot. We're likely to see the need for such rationing here. So the central question is, given a limited supply of medical resources, of ventilators, of personal protective equipment, of ICU beds, of medical professionals themselves, of palliative care drugs, of vaccines, how should we decide who gets them? This is a question of triage and rationing. It's a question that forces us to decide who gets what treatments and in what order they'll be treated. It's a really difficult question that kind of upends the standard practice in modern medicine, which is save at all costs. We have to try to save the patient at all costs unless the patient has decided otherwise. When a patient is in front of you, you don't withhold care from them because you think someone else could benefit from that care more. You don't withhold care from them because you think the resources that they're going to use could be better applied to someone else. You don't withhold care to them because you think it's not the best use of your time or your expertise. You let the patient decide when it's time to stop. And if a patient is coding in front of you, you do all you can to try to save them. But now we have to consider whether saving this patient entails sacrificing others. Because of the limited resources that are available, we have to make these difficult decisions about whether saving the patient that's in front of us is in fact harming other patients that could be saved, whether we ought to refrain from saving this patient in order to benefit those others. We also need to consider whether saving the patient uses limited resources to little benefit, either because the patient is likely to die anyways, and has a poor prognosis, or has already lived a full life, or will have a low quality of life, or has little life left to live. We want to maximize the benefit to the most patients that we possibly can, and if we use our resources to little benefit on one patient, that seems to not be the most effective use of the limited resources we have. And we also need to consider whether saving this patient puts medical staff at too great a risk. We're seeing a number of hospitals now consider universal DNR orders for COVID-19 patients. That is, that when a COVID-19 patient codes, they won't be saved. Because it puts medical staff at such a great risk and uses so many resources, so many PPEs in attempting to save this individual patient that it's deemed too costly. And in hospitals where they're not considering instituting universal DNRs, they are at least trying to convince COVID-19 patients and their families to sign DNRs to protect the staff and resources of those institutions. So these are all things that now come into consideration. One of the papers I asked you to read was a paper by Ezekiel Emanuel and others on the allocation of scarce resources during the COVID-19 epidemic. This paper proposes a number of ethical values and guiding principles to help us think through these questions of rationing and triage. And I want to spend just a couple of minutes looking at each of the proposed principles that they put forward. The first is the principle of maximizing benefits. And the idea here is that we ought, under conditions of resource scarcity, the best we can do is to try to maximize benefits for the community. So we ought to aim to do the greatest good for the greatest number. Because we can't save everyone, because we can't give everyone this life-saving care, we ought to try to use the limited resources we have to do the most good, to create the most benefit that we possibly can. And the way this is operationalized is twofold. First, it says we should save the most lives that we possibly can. And then it says we should save the most life years that we possibly can. This is a staunchly utilitarian stance. We have limited resources available. We must use them to do the greatest good for the greatest number. But we might worry that this staunchly utilitarian stance has some really problematic implications. We might worry that it is ageist. If we are aiming to maximize the most life years, we do that by saving the youngest patients and not the older patients, because they have fewer years to live. They've lived a fuller life already, and so it is sometimes thought have less to lose in dying. But this might be really worrying, because it means that we are treating elderly patients inequitably. We are discriminating against them on the basis of their age. And they are already disadvantaged because they have a poorer prognosis, and so maximizing benefits already disadvantages them because they're less likely to be saved by the use of the resources that are available to us. We also might worry that this is ableist, because individuals with disabilities might already have fewer years to live, might already be expected to have a shorter life, and so might be deprioritized by a principle that says we ought to save the most life years. Now we should note that one principle that is rejected by Emmanuel and others, and by nearly everyone who's talked about rationing care in COVID-19, is the use of quality adjusted life years, or QALY. Quality adjusted life years are subject to a significant critique through the disability rights lens, because able-bodied persons tend to undervalue the quality of life of disabled individuals. We tend to think that their quality of life, or tend to assess their quality of life as lower than they themselves would assess their quality of life. And as such, if we use quality adjusted life years in making a decision about who's going to receive care, then we will in fact operationalize it in an ableist way. We also might worry that this is a violation of ideals of autonomy and beneficence, which seem to require doing all you can for the patient in front of you. The ideal of autonomy is an ideal or principle of medical ethics that says that the patient ought to be the one who decides what is in their best interest, that patients have the capacity, and that their capacity have the capacity to decide for themselves what is in their best interest, and that capacity ought to be supported. And beneficence is the principle that says that we as medical providers ought to do what is in the best interest of our patients. But if we are making rationing decisions on the basis of saving the most lives or maximizing benefit, then we might be deciding for patients that they're not going to receive care that they deem to be in their best interest, and even that they're not going to receive care that we deem to be in their best interest. So we may be violating autonomy and beneficence. But perhaps under conditions of severe scarcity, as we are facing during a pandemic, this is just what is required. Perhaps when we turn to a public health lens instead of our traditional bioethics lens, we will see that this is just what is required. These are questions that we should spend some time talking about when we meet this week. The next principle that Emanuel et al. Propose is to treat people equally. There are different ways that this principle can be operationalized. It may be operationalized on a first-come, first-served basis, but there are some problems with this. First-come, first-served privileges those with greater access and closer proximity to medical resources and to healthcare centers. And it's not the most effective use of limited resources, because patients who are more likely to benefit from the limited resources that we have may arrive later and should be prioritized. So first come, first serve seems a problematic way to treat people equally. Perhaps a better way is random selection or lottery. This maintains fairness among patients with similar prognoses, and so that seems to be a way of treating them all equally. We also should, they say, treat COVID and non-COVID patients equally. This rationing applies to all. Patients that come in after a motor vehicle accident as a result of a heart attack are also using these same scarce resources, and this rationing must apply equally to all of them. What we might wonder, though, is whether it follows that those with more severe prognoses are not being treated equally. There are different ways to operationalize equitable treatment or equal treatment. We might think that equitable treatment means treating each person in the same way, that each person receives the same resources, but that's clearly not what Emanuel and others have in mind, and it's usually not what we have in mind by equitable use. We shouldn't be using the same resources for everyone because not everyone has the same needs. Another way to operationalize equity is to think that each person ought to receive what they need, that each individual ought to receive the care that they need. And in normal times, this is often what we do. We try to provide each person with the appropriate care for their condition. But that can't be used under conditions of scarcity because not everyone is going to be able to receive the care that they need. So the way we're trying to operationalize treat people equally in this case is in terms of giving each person their due, where we're making value judgments about what is due to each person. What is due to each person is determined on the basis of this utilitarian calculus of maximizing the overall benefit that we can provide. But this has, as we've already seen, some ageist, some ableist consequences, and we should really take some time to concern ourselves with those, to attend to those, to think carefully about them. Emanuel and Emanuel also say that we ought to promote and reward instrumental value. In a retrospective way, we ought to prioritize those who have provided relevant benefits. We ought to prioritize the care of healthcare workers and research participants. They should receive priority when all else is equal. This supports healthcare workers in the fight against the disease. It makes them feel supported. It motivates them to continue engaging in this incredibly risky fight that they are engaging in, because they know they will be cared for. We also can enact this prospectively by prioritizing those who are likely to provide benefits. We need healthy healthcare workers, healthy frontline healthcare workers, in order to fight this pandemic. So these healthcare workers ought to be prioritized for testing and treatment, so that we have healthy frontline workers out there fighting the pandemic. This might also speak in favor of a universal DNR. This might be a way of prioritizing the well-being of healthcare workers because of the instrumental value that they have. And finally, Emanuel et al. Say we ought to give priority to the worst off. We ought to treat the sickest first. That's usually what we do in medicine. We ought to treat the sickest first, but they say only when it maximizes overall benefit. So this applies to testing very clearly. We ought to test the sickest first to identify cases of COVID-19 because that maximizes the overall benefit by isolating those cases and being able to trace their contacts. But it might not apply to advanced care if a patient does not maximize benefit. If the sickest patient has a poor prognosis, then perhaps we ought to prioritize the patient with the stronger prognosis. They also consider that we ought to prioritize younger patients. We ought to treat the youngest first. They say that this should only be done when it can be shown to maximize benefits. It might be the case that this maximizes benefits in terms of providing advanced care, providing a ventilator to a patient, for example, but it might not be the case that this is what we ought to do when it comes to vaccines or testing. Perhaps we ought to focus on those who have had the most contacts with others in terms of testing, or those who are frontline healthcare workers in terms of testing, or the elderly in terms of testing, so that we can identify COVID-19 as early as possible in them. And for vaccines, it depends on the epidemiological models. If they show that the greatest benefit comes from vaccinating the elderly first, then that's what we should do. If it shows that it comes from vaccinating the youngest first, then that's what we should do. We should let the science lead the way there. So that's a quick overview of Emmanuel and the arguments that they are providing, Emmanuel and others, and the arguments that they are providing here. The principles that they're trying to give us as we think through these questions of rationing and triage, the allocation of scarce resources. I hope in class this week we'll have some time to really reflect on these questions and any others that you have that arise out of this condition that we've all found ourselves in now. Any other questions you have that arise out of your own thoughts or that arise out of the readings that are available to you on my website. I'm happy to explore any of those with you this week, and I really hope we can have some great discussions. Until then, be safe, be well, take care of yourself and your families, and stay home.